Hey guys, this is Nay here. Welcome to my channel, The Ready Nurse Nay. Today is part 2. I am going to give you a little overview, the good, the bad, and the ugly of my ICU clinical week 2. Okay, so I had clinical last week. I made a video about week 1. Today I'm going to make a video about week 2. I had clinical today, all day, today from about 6 to like 2:30, 3 o'clock. And then, came home, took care of my family. And yeah, so busy. It's crazy how I'm tired mentally, but physically I'm okay. So let's talk about my day today, okay? The good, the bad, and the ugly. All right. So we're on a cardiovascular ICU unit at a major hospital. And typically when we get there, our teacher pairs us with a nurse, and we take care of that patient for the day with the nurse. Okay, and so this week I got paired with the same nurse that I was with last week. Really great nurse, really nice. So the good, a little bit of incident. This patient, had open heart surgery. Basically was recovering from open heart surgery. So this patient was in the ICU, just recovering from the surgery, dealing with a lot of pain. Had some other tubes, drains, and lines, and all kinds of drips and all kind of stuff to stabilize this patient and make sure they were okay. So yeah, that was basically their main things going on. A lot of drips to maintain their blood pressure, and a lot of stuff going on to maintain their pain. So yeah, so that's the background story. So what's the good from today? The good is that the patient was very, very nice, loving family. The family wanted to talk, which was nice, because you're able to kind of learn more stuff from the family members, and it just helps put the patient in a happy mood. When you're sick, you want to be with your family members, and the same as when people are in the hospital. When they're sick, they want to be with their family members, and it just makes them happier. It can make your job easier, especially if that family member is maybe helping take care of the patient, maybe helping clean them, or even helping to feed them or something if they need help with that. That makes things easier. So that was good. And also I think a supportive family kind of helps with increased patient outcomes. It's like that extra encouragement and strength that they need to push through if they're hurting, push through the pain to get better, or push through rehab and physical therapy to get better so that they can go home to their family. So it just helps increase their outcomes. So that was good. It's also nice too when you have a patient that is awake, alert, oriented, to person, place, time, and situation. They know who they are. They know why they're there. They know what calls for them to be there. They know, they're with it. They're with it. When you have a patient that can talk to you, that's with it. They understand. Their understanding is appropriate for their age and stuff. It just makes it easier because they can tell you if they're hurting. They can tell you if they're hungry. They can tell you if they're nauseous. They can tell you, if they're sad or something. You don't have to guess it. So when you have a patient that's with it and they're able to communicate their needs to you, it makes things so much better. So that was the good today. Let's talk about the bad. Yeah, let's talk about the bad. So the bad, I think, for this unit with us and with students on this unit, this ICU unit, is just a very, an extreme lack of autonomy. We have a way higher lack of autonomy than I've had in any other unit. In all the other units that I've worked on all over the hospital, and all these different hospitals, I've had more autonomy to be able to actually use critical thinking and nursing skills than I have had on this unit. Lack of autonomy. And the lack of autonomy is because it is new skill, new equipment and new things that you're doing. So you have a lack of knowledge. So you don't know, you have to go look it up, to find out what's going on. And if you don't know, you might not be comfortable with performing that task, whatever. So then, you might miss out on that opportunity. You might so that you can learn about it and then do it the next time. But definitely a lack of autonomy. It's a lot of, because the patients are very sick, it's a lot of checking in with your teacher, checking in with the nurse, as far as all the meds and all of the procedures before you're able to actually perform any of that on the patients. So just an extreme lack of autonomy, which it just kind of can make it difficult. You can't move how you want to move and really make those critical thinking judgments and skills when you have that lack of autonomy going on. You can't do as much. You're very restricted, between your teacher and your nurse. You're very restricted on what you can do. I think another bad thing too is just miscommunication. There's a lot of kind of miscommunication between teacher and students and the nurses on the unit as far as what the students are allowed to do in this unit, what we're not allowed to do, and even like checking off. A lot of on this unit, because it's an intensive care unit, we have a lack of autonomy. So on med surg units, ER units, we're able to kind of like flow like water. On this unit, it's kind of like I feel like we're in like a coffee mug. We have to check off on everything before we're able to do it with a patient. And so, mind you, it's 7 students. So we have to go find our teacher, check off with it before we can go back, let the nurse know, and then perform that or give that med. And so the nurses don't really know that. So when they need you to do something now, they're like, I need you to do this now. I need you to do that now. I need you to take a blood sugar. I need you to grab a pain med and give this now. You're like, I'm sorry, the process is I have to check this off with my teacher. If I do this without checking off with her first, I can get in trouble. I can basically get a write-up, and after so many write-ups per semester, you can get kicked out. So that's a way of, as a student, covering yourself. Always covering yourself. Your nurses may not know what you're allowed to do and not allowed to do, and that can be different per clinical instructor based on what they feel is that they're comfortable with allowing you doing and what not allowing you doing. So find out what your instructor is comfortable with allowing you doing and not allowing you doing, and then do that. Even if the nurses are like, grab this, you can do it, you can just use my badge. I don't want to get in trouble. Okay, you are already nurse. I'm right there to next to being one. Okay, and I'm not about to have the rug pulled from under me because you want me to do this little. No, I gotta check with my instructor. I'm sorry, that is just the protocol. So that's how you covering yourself as a student. I guess another bad thing, but not bad thing, is that you are seeing a bunch of new stuff that you're not familiar with. So a lot of times when you go into this unit as a nursing student, especially these high specialty areas, like they're gonna these nurses, they expect you to know it all. Your teacher may be expecting you to know it all, and you don't. So just new equipment, new skills, and you may not be familiar with it. That can kind of be a bad thing, especially if you're not comfortable or they don't make you comfortable enough to ask them, like, hey, what is this? What is that? Then you basically have to look it up on your own or ask somebody that you're comfortable asking. So, yeah. The ugly. Let's talk about the ugly today. So I would say the ugly that I experienced today wasn't super ugly. Is that there are, my nurse is a good nurse, but she's not, she wasn't a great teacher, for me as a student. And it could be that's not her job. She's a nurse, take care of the patient. She's not a teacher. It's my teacher's job to teach me. But sometimes that can be a little gray area because your teacher might expect you to know a lot of stuff. That's what they expect you. And if you ask them a question like, you should know this, then you have to go look it up and figure it out. So, which ends up kind of being a weird situation for a student. Okay. And also there's a scale, think of a continuum. You got good nurses and they kind of make their decisions and their judgment calls on this continuum. On this little scale, you have rules, following the rules to a T, kind of best practice, and then bad practice. And sometimes nurses kind of move in and out of those decisions to, those within that scale to make their decisions. Okay. A lot of times in nursing school and with your teacher, they're teaching you on this side of that pencil, on this side of the continuum of following the rules 100% in this perfect environment. You're following the rules. But sometimes in the real world, the nurses on the floor actually in practice are more in this best practice, and I don't want to say bad practice, and they're making kind of decisions throughout there. They're never quite all the way over here, which can kind of make things sticky too, because they may have something in the med chart that's this is how you give it and this is how you dilute it, but then the nurse, maybe based off of that nurse's clinical judgment or best practice, is kind of making decisions to kind of come in here. And that nurse might want you to be right here, but you're I'm sorry, I can't do it that way. I talk to my teacher, I have to do it exactly like it is in their chart. Okay, if you want to do it that way, you can go ahead and pull it and do it. And so as students, we kind of have to follow the rules. Your teacher will let you know you're following the rules. If they say some of the other stuff is okay, that's fine. But I would say a good rule of thumb to just kind of cover yourself as a student, we follow the rules. And if that nurse that you're working with that patient wants to do it some other type of way, you can review it with your teacher. If they say that's okay, that's fine. But if they don't, just say, hey, I can't do it that way, but you can do it how you want to do it, then they do it and give it how you want to give it, right? But you just cover yourself, because this is what we're taught in school in this perfect world. But in real life, nurses on the floor kind of work more towards this continuum and this best practice, what they think is best practice. And I don't want to say bad practice, but kind of like in there. Okay, but as a student, we're right here. So I would say that. And then I guess another thing, like I say, the ugly could be that there are a lot of good nurses, but not all the nurses on the floor are good teachers. They're not necessarily patient with you as a student, and it could be because they're just busy, especially on the ICU unit. The patients are really, really sick, so they're working quick and fast to get medications to them and get interventions and skills performed on them quickly. And it kind of puts the students in like a little weird spot, because the nurses are moving quickly. They need it done here, now in that ICU unit. But as students, it's like, I don't have the autonomy just to do it right here and now. Like, you need it, I have to check it off with my teacher. I have to find her, and it may take 30 minutes for me to find my teacher and check it off before I can come back and do this skill. So if you need it done now, it may be quick to just do it. But then you might end up as a student missing performing that skill or whatever, because you have to do the protocol. But it is what it is. Follow the protocols that your school and teachers set in place, so that you don't get in trouble. So I think that's just really is how it is for today. That was my good, bad, and ugly. It's specifically for today's clinical. Yeah. And I guess it's almost focused on like just covering yourself as a student. Like if your nurse is asking you to do something for a patient or give a med a certain way that is contrary or different than what's on the chart, you kind of need to check it off with your instructor first. And then if your instructor says, hey, it's okay to do it like that, that's fine. But if your instructor says, no, we're going to do it how it says in the chart, then that's kind of that. You can then you could tell your nurse, hey, instructor says we got to do it how it is in the chart. If you want to do it somewhere else, you can pull it and give it how you want to give it. So, yeah, that's kind of, I guess, how my day was as far as on the unit today. I'm glad that it's over. Yeah, I think at this point in time with clinicals, I think when I first started nursing school, I was super excited about clinicals, but now I'm just like, it's just working for free. It's working for free, and I'm ready to be over it. So 2 more weeks of ICU clinical, then we're going on back to old school stomach grounds. We've had like almost a year of med surge, so I am so comfortable with med surge. I'm comfortable with the craziness of it. So after 2 more weeks of ICU, we'll be doing 7 weeks of med surge, and I'm ready for that craziness, because that's what I'm familiar with. So peace, blessings, see y'all in the next video. Bye.